Fowler. I'm a family medicine physician here in Raleigh. I work at WakeMed Primary Care. And as was mentioned, one of my passions is cancer screening and prevention. As a primary care doctor, I do this every day in my office with individual patients. And by being able to be co-chair of the North Carolina Advisory Committee on Cancer Coordination and Control, and work with Jenny Denai on our subcommittee for early detection, I feel like I've been able to take what I do daily in the exam room and kind of spread it around. And this is one of those opportunities whenever I'm asked to speak about cancer prevention and cancer screening, I always say yes, because if I reach you today and I give you information and you carry it home and you share it with your friends, share it with your family, share it with people in your community and people you work with, if we reach another person and save another life, then my time is well spent. So I've been told I have 20 minutes. A tough road for me, but we'll try. I have a lot in this talk, and it's geared toward just anyone. This is a talk I can give to you, hopefully to my mom or my friends, or to the medical students and residents that I teach. And it's kind of heavy, it's got a lot of stuff, but I hope at the end of this, you'll come out of this with lots of information that will help you spread the word and be more enlightened. The learning goals for today is to understand the burden of lung cancer. With many of you know, if you've had cancer, the burden for you and your family, but I'm going to talk about the burden of lung cancer for the population in the world and our society and in different populations. So why do we screen? It's a terrible disease, it's a huge burden. Identify the risk factors for lung cancer, so who to screen, who's at risk. Review the signs and symptoms of lung cancer, who not to screen. What that means is if you have signs and symptoms, you need a diagnostic imaging. You need more testing, more advanced testing than if you don't have symptoms. And understand the current lung cancer screening guidelines, so that means when and how to screen. So there are two main types of lung cancer, just briefly mentioning. There's non-small cell lung cancer, 80% of lung cancers are this type. There's also small cell lung cancer. Luckily, only 10 to 15% are that type. Those cancers are often more aggressive at the time of diagnosis, they're harder to treat, and their survival, the mortality is greater. But luckily, that's a small percentage. The risk of dying from lung cancer is higher in people who smoke, but 20% of people who die from lung cancer have never smoked. And I'm from rural North Carolina, where I practiced in my hometown for 14 years, and the faces are just going across my mind right now of all the sweet little old ladies I diagnosed with lung cancer, and they've never smoked a day in their life. Lung cancer accounts for 1 in 5 cancer deaths each year. Lung cancer is actually the leading cause of cancer death worldwide. And this slide has a lot of numbers, a lot of big numbers with a lot of decimal points and commas. Lung cancer is the leading cause of cancer death in the United States in 2020. But looking at lung cancer in the United States, estimated for 2023, almost 250,000 people are going to be diagnosed with lung cancer this year in our country, and over 125,000 people in our country will die from lung cancer. The leading cause of death in North Carolina, lung cancer, in 2020. And estimates, because I don't have these numbers, I don't have the statistics yet for 2022, but almost 10,000 people were diagnosed with lung cancer in North Carolina, and almost 5,000 people died of lung cancer in North Carolina, estimated in 2022. This is my favorite slides, and I highlighted the important part in yellow. This points out for men and women, lung cancer is the second leading cause of cancer for both men and women, but most importantly, it is the leading cause of cancer death in men and women. And the other take-home message, if you could read the numbers and you had a calculator, deaths from lung cancer are greater than or equal to deaths from breast cancer, prostate cancer, and colon cancer combined. I'm going to go to this slide, and I'm going to come back. This is incidence. Incidence is the number of cases that occur in a certain time period. So this looks at basically for about the last 50 years. The top line is men, the bottom line is women. What do you notice? They started to meet in the middle. The incidence of lung cancer in men was declining up to 2018, And in women, you kind of see women didn't smoke as much as men, and then when they kind of picked up the habit and smoked more and more, their risk of getting lung cancer went up. Luckily, it has kind of leveled out over the last 20 years and maybe subtly starting to decline. This is deaths. You can see trends in death rates, and this is over almost the last 100 years, like 90 years. You can see men peaked and started to come down, and I think that's due to advancements, probably treatment and surgery. In women, when women started smoking, their risk of death from lung cancer went up, and it's plateaued, but you can see how those lines are getting closer together. It's really important to keep in mind differences in lung cancer in both your race and your ethnicity. And the bright red arrows point out some information the American Cancer Society has recently provided. And you can actually see that for African Americans, Black individuals have a higher incidence of lung cancer than white. And then interestingly, with mortality, you can see that Black and actually American Indian and Alaskan Natives have higher mortality. So there's something going on there. So there's racial differences. And that is important when it comes to screening, and we'll talk about that a little bit later. Recent statistics within our state point out some interesting disparities, perhaps in all incidents of cancer, but also in the kind of treatments that people get once they're diagnosed with cancer. Kind of interesting, it's hard because I don't have a pointer, but the take-home message for me when I looked at this data was there's the early diagnosis of lung cancer among Black Americans, which is that top line over there on the right, those top two lines, a little bit more lung cancer being diagnosed in African Americans, and the very next line down, less surgery. Surgery is when you're catching it early and you're hopefully curing, right? Surgical, when you see surgical treatment of cancer, that means, number one, the patient was a candidate for surgery, and you caught it early, it's not spread, and they had access. So I don't know what's going on. We need to know what's going on there. Is that access? Is that willingness to have surgery? Why did that happen? There's also some really interesting among Indigenous Americans. This is in the state of North Carolina, in our Indian population. Pretty neck and neck over there with the early diagnosis for both whites and Indigenous Americans. But then you look at surgical treatment and there's a huge difference. So what's that all about? So we actually have to look. Your patient, it's individual patient, individual grouping of patients. What are we doing differently? What are we doing right? What are we doing wrong? But the bottom line is, we're just failing across the board. I'm a primary care doc. I'm supposed to screen for cancer, educate my patients about prevention. In lung cancer, we are failing. We're doing great in some things. 5-year cancer survival rates, all of you who've had cancer, that's what you're going for. You're looking for that 5-year mark. I always love it when my patients come in and they're like, it's been 5 years. It's just such a wonderful sense. I've made it to that 5-year rate. 5-year cancer survival rates in our country. 90% for breast cancer. Look at the screening rates for breast cancer, 88%, right? Eligible people that could get screened, but 88% are getting screened. Colorectal cancer, 5-year survival rates are 63%. 69% of people who are eligible are getting screened. We need to do better on colorectal cancer screening. We gotta do better. We should have it up to 95% on all of those. Third line, circled in red, lung cancer. 5-year survival rates, 21%. Look at our screen rate. This is insane. 6% of eligible patients. We've had guidelines out for a decade. 6% of eligible patients are being screened. In North Carolina, we're a little bit better. We're 8%, the last data I saw, but that's really sad. Highlighted in yellow is just pointing out something that I find really fascinating. I mentioned there's non-small cell and small cell. If you catch cancer early, localized cancer where it surgically can be resected, 63% of people with non-small cell will survive 5 years. It's only 1 in 4 for small cell. But if you catch it early, it's 1 in 4. If you don't catch it early, it has a very poor prognosis. So there's going to be a lot of discussion, questions about who do you screen. And primary care providers, they're not always sure who to screen. The reason we're here today, the reason we work every day, who do you screen? Who do you, who's your at-risk population? These are some of the risk factors. Current and past history of smoking, number 1. Number 2, exposure to radon. I'm going to talk a little bit about radon gas and what that is. Prolonged exposure to secondhand smoke. smoke. Thousands of people die every year in our country because of secondhand smoke exposure, being their only real risk factor, we think, for getting lung cancer. Previous cancer of any kind, where you had radiation therapy to the chest, and then your occupational exposures. There's a gauge rubber in my hometown. If you work in a rubber factory, exposure to some of those chemicals is an occupational risk. Asbestos, if you work on the highway, if you're a diesel mechanic, if you're paving roads, if you're laying roofs, these people are at increased risk. Family history of lung cancer. Anyone with lung disease, if you have COPD or pulmonary fibrosis, you have increased risk. And a prior diagnosis of lung cancer, of course, you're going to be screened and monitored closely. These are people you want to be thinking about. I'm talking a little bit on this slide about lung cancer and tobacco use. Smoking is the leading preventable cause of lung cancer, and honestly, smoking is the leading preventable cause of all cancers, not just lung cancer, colon cancer, breast cancer, all cancers. I am not confident how they managed to achieve this, but tobacco smoke is a toxic mixture of more than 7,000 chemicals. Sometimes I don't know, is that true? I probably haven't done that, but that is the data that's out there from the American Cancer Society. 7,000, it's like they're trying to kill us. How do they do that? How is it possible? I grew up on a burley tobacco farm in North Carolina. My dad raised tobacco. I graded tobacco. We sold tobacco. My Christmas depended on how good the tobacco crop was that year. So the amount of chemicals that went on that tobacco in the field was what people were smoking when they got it. But we had to have pretty tobacco plants. Prettiest leaves sold the best. So I grew up going to the tobacco market with my dad. So glad we don't see those tobacco fields in my hometown anymore. Cigars and pipes also increase risk. Quitting smoking at any age reduces your risk of getting or dying from cancer. I mean, there are so many patients I see, they're like, well, you know, doc, I've smoked so long. You'll learn in the guidelines, if you quit today, there's a point in time where we're not even going to worry about you anymore. So that's really important. So we have this number. There's no way you can do a talk about lung cancer screening and tobacco without explaining the term pack years. And doctors, we throw this around right and left. People have no idea what we're talking about. So you measure cigarette use in pack years. So what do we mean, okay? How do you know your pack year history? I'm a Carolina grad. My husband's an NC State grad. Kind of came to me last night. My husband, Conrad, he came to NC State in 1981. And so he has a 42 wolf pack year history, right? So, but that's not what we're talking about. I'm talking about this wolf pack history. We're a house divided. Anyway, so how do you know your pack year history? Oh, it's simple math, right? Number of years smoked, packs per day, do the math. That's your pack year history. That would be great, right? 10, say you smoke for, 10 years, 2 packs a day, that's 20 pack years. Maybe 20 years, 1 pack a day, that's 20 pack years. It's not that simple. Say somebody's 50 years old and they come in your office and they're smoking half a pack of cigarettes a day, and you say, how long have you smoked? And they say 20 years, and you do the math and you say, oh great, 10 pack years. That's not the story. You say, when did you start smoking? How long have you been smoking? What were you smoking when you were smoking the most? Oh, college was really stressful, that divorce was really stressful. You were smoking 2 packs a day for 10 years? Oh, but doc, that was 10 years ago. Now I'm down to half a pack. I've been really working on it. They qualify. You have to take a good, thorough history. And one of the problems we have in our electronic health records, we don't actually have a good way, using our electronic health records, to calculate someone's pack year. Because every time you come into my office, my staff says, how much are you smoking? And if you say I'm smoking half a pack, they put that in, it redoes the math. So it's really hard to pull this data out of an electronic health record. It requires a conversation with your provider. That's a lot about tobacco. This is a little bit about radon. Radon gas is odorless, it is tasteless. You cannot tell you're being exposed to it. It is the second leading cause of lung cancer. Radon exposure in homes and businesses can be decreased. It is a preventable cause of lung cancer, but you have to know you're being exposed. And you can figure this out if you're a homeowner, if you're a renter. You can get a very inexpensive kit. You can get them free. You can buy them at the hardware store, and you can figure out how much radon gas is in your home, especially basements. If you have a basement, you really want to know. most corner up there in Ashe County between Allegheny and Watauga, they're bright red and we're orange, but lots and lots of lung cancer in my hometown, which I'm convinced is due to radon. And then it's kind of worrisome to see Wade, Franklin, and whatever county's above that, Wade, Granville maybe. These are all very hot spots too. So radon gas, if you are a smoker and your home has radon gas, it's a multiplier. You don't add that risk together, they multiply each other. It's like 30 times greater risk of getting lung cancer if you have both. So we're talking about screening for lung cancer. We don't screen people who have symptoms. If you have symptoms of lung cancer, you fall into another basket, you fall into another rubric, another flow chart, right? So what are the signs and symptoms of lung cancer? So if you have a persistent cough, a cough that wakes you up at night or you're coughing up blood, there may be another explanation. It could also be cancer. If you get pneumonia or bronchitis and it occurs over and over and over and doesn't seem to clear, there may be a reason for that, but it could easily be cancer causing that. Wheezing, shortness of breath, chest or shoulder pain. There's lots of people that come to my office with these complaints, but depending on their risk, I have to consider, could this be cancer? Is this something we need to work up further? And hoarseness, swelling of the face and neck, and loss of appetite. There's some reasons, just these next few slides sort of tell you why. Why would I have those symptoms from lung cancer? So regional, like local symptoms or symptoms within your lungs, if cancer is blocking a bronchial tube, it can make you have cough and shortness of breath. You can have chest pain if it's spread outside the lungs. If it's involving your vocal cords, you can have hoarseness. And sometimes people just have swelling of their face, and that's because it's causing pressure on blood vessels that are returning blood flow, and it's obstructing normal blood flow. And so you're having issues where you're having swelling. This is where you don't want to be. We want you to get screened. We want our patients to be screened because I do not want to diagnose metastatic lung cancer. Someone who has back pain, it's been going on for a long time, they haven't gone to their physician about it, they just thought it was nothing, and then I see them order an x-ray and find out it's metastatic cancer. So that is not where we want to be. We want to be finding people early. And then later signs, cancer can spread to your brain, to your liver, to other glands and organs, and cause systemic symptoms, we say. Weight loss that's unexplained, loss of appetite that's unexplained, especially in the patient who's at risk, the smoker, the person who's been exposed and has a family history. And if your sodium is low, or your calcium is high, and if anyone has blood clots, if suddenly you have a blood clot in your leg, blood clots in your lungs, when you have cancer, it increases your risk of blood clots. So whenever I was in training, and we don't do this anymore, but if anybody had a blood clot, they had to have an extensive scan from stem to stern looking for cancer. Basically, now, if I have a patient who has a blood clot, I just want to make sure they've had all their routine screenings. If you come in and see me and I diagnose a DVT, and I'm suddenly talking about your colonoscopy, I'm really doing you a service. When did you last get screened for cancer? Because cancer makes you more likely to have blood clots. So if you have symptoms, if you have signs, you get diagnostic imaging, you get a referral, you get worked up for that. But sometimes you don't have any signs or symptoms. As Terry was saying, you can have very significant cancer or disease but have no signs or symptoms. So you want to have screening. We want to screen for cancer, pick it up early when it's still treatable. And this slide for me is just something that you have to keep in mind when you're trying to find a good screening test. A good screening test is a screening test that's going to pick up a disease that is very serious, has terrible outcomes if you don't find it early, but if you find it early, you can cure it, you can treat it. Early intervention is actually available, and the cost of the test is reasonable when you consider the benefit, and the test is available and safe. So luckily, we have that for lung cancer. When I finished training in 1999, we didn't know this. This was not known. But this research was underway. Low-dose CTs are shown here. And I think the important thing, I'm going to walk over here and kind of point out. On the bottom is what you see on a CT scan, a diagnostic. This is a diagnostic CT right here. How clear and beautiful that is. But if you want to look at something in your abdomen or your kidneys, this is really grainy. That's not real great, right? Like you really want to get this image. But look at the lungs. They're almost the same.
almost the same. You can actually, there's an arrow, if you can see it, for a lung nodule. I'm not a radiologist. My imagination is not that good. So, but that's a lung nodule. They know that. The difference, 10 times less radiation for that scan than that scan. You have 10 of those for one of those, okay? So the amount of radiation exposure for a low-dose CT, I've read that it's the same as flying from the East Coast to the West Coast. That's the amount of radiation you get from that scan. So there's this wonderful scan. They figured out that it is much less radiation. It shows the lungs really great, but is it good? Is it a good test? Does it pick up what we want, and will it prevent death? Will it improve mortality? So I want to just mention these. I think this is a really important. I give this lecture to students, to residents, to doctors, but I think everyone needs to understand how did we come to where we are today with the current guidelines. And for me, there were 3 pivotal studies. This is a study we call LDC, the NLST. The NLST trial looked at over 50,000 people, over 33 medical centers. People were being recruited for this when I went out to practice. I remember, I think one of the hospitals in the state was recruiting people. And they looked at the ages 55 to 74, but these were high-risk people. They had smoked 30 pack years, and they were still smoking or were within 15 years of having quit. Because as I said, once you get past 15 years, your risk has gone down. If you don't have cancer already, you know, your risk has gone down. So that was the population. These are pretty high-risk people, and they put some of them in a pot, and they got low-dose CT. They put some of them in a pot, and they got chest X-ray, and they followed them. And this is what they saw. And so you kind of go from the top, and that's what we put in. We went down, and they looked at these people, one at baseline, 1 year, at 3 years, 5.5 years, and compared them. How many people died of lung cancer? And on the low-dose CT side, they had 354 deaths. And on just chest X-rays, they had 442 deaths. 88 people lived that wouldn't have lived because they had a low-dose CT. So this, we look at scientific studies as relative risk reduction. Sometimes you say absolute risk reduction, but in this case, relative to chest X-rays, how much better was a CT? 20% risk reduction for lung cancer death, which was really significant. And this was published in the New England Journal of Medicine in 2011. 2 years later, we suddenly had guidelines. So 10 years ago, we had guidelines for CT screening, low-dose CT, and they decided to start at 55, 30 pack years, base the whole thing on this. There's a problem. There's a lot of white men who smoked a lot in this study. Just so happened there were very low percentage of African Americans, and women, we just didn't smoke as much. And so there weren't as many women being screened with low-dose CT. So even though we came out with guidelines a decade ago, luckily scientists didn't stop there. There was this really important study called the Nelson trial. It's from it's a Dutch and Belgian trial. It was a population-based control trial, and they said, you know, if we look at people, maybe they smoked a little bit less, maybe they're a little younger. Let's see if what we find if we do a CT on them. So in this group of people, there were a lot more women because they said you smoked for 15 pack years. So half a pack a day for 30 years or 1 pack a day for 15 years, you got in the study. And they started at age 50. Instead of 55, they started at 50. And they looked at them the first day of the trial, 1 year, 3 years, and ultimately went all the way out to 5.5 years. And then after maybe a decade, they published this. Again, the New England Journal of Medicine, my Bible of medicine. In 2020, this was published. And the funny part was the control group, they didn't necessarily do chest X-rays. They just did what's called routine care, whatever your doctors decide to do. Whatever happens, happens, right? But we're going to screen these others. And this was crazy good. I mean, this was amazing. Relative risk reduction for lung cancer deaths, 26% reduction for men. If you do this screening, women almost 40%, because women don't smoke as much as men usually. And they caught those women. And so this just blew the whole thing out of the water. This was published in 2020, 3 years ago. And we remember, Jenny and I do, because Jenny and I have been really hard at work for a long time trying to put together what we call a toolkit. A a screening toolkit, like we wanted to provide information to physicians on who they should screen. And we're working, and then this came out. We're like, okay, maybe we should wait a minute, because the guidelines were almost a decade ago, like 7 years ago, and they didn't seem to be keeping up. Like, hey, women really, we want to know if we have cancer, right? But guess what else? There were not many African Americans in that original study. But luckily, somebody did this study. So there's something known as the Southern Community Cohort Study. These are 12 southeastern states, and North Carolina's in there. All 12 southeastern states. And this is a really underserved, at-risk population of individuals who go to FQHCs, federally qualified health centers, and many of them are African American. And this cohort, this group of people that are being looked at across these 12 states, range in age from 40 to 79. So someone decided, hey, let's take the 2013 guidelines and let's apply them to this group of people, and let's see what we get. Well, when you look at the black patients and you look at the white patients, when you use the original 2013 guidelines, you get about 56% of the lung cancers in the white patients you pick up with screening. Only 32% of the African American patients were having their cancers diagnosed by screening. So they looked back at it again, they looked at the data again, they looked at everything again, and they looked at the numbers and they said, well, what if we dropped it to 20 pack years? What if we just changed the 30 to 20? Would we have caught those people? And voila, that was the difference. So there was a study published in the Journal of the American Medical Association Oncology, and this was in 2019, that said you really didn't get it right the first time. If you want to find lung cancer in black patients, you need to drop it to 20. So here, women need to have the pack years drop. African Americans need to have the pack years drop, because we're missing them right and left. And they did a statistical analysis, and I hate statistics, I don't understand them. But I know when the p-value is really low, that's really good. And so they did a statistical analysis, and they looked, if you change it to 20 pack years, you basically increase the ability to find those African American patients, but you didn't do anything to overdiagnose the white patients. And so we're going to talk a little about overdiagnosis. If you screen, sometimes you overdiagnose, but they didn't see a problem with that. So this is what Jenny and I were living in the world back in 2021. So we were trying to publish and put out online screening tools that told everyone what to do. And right in the middle of us, in the middle of a grant, we had a grant, grants run out. We got money for a little while and then it's gone. Right in the middle of all that, they changed the guidelines, which is great. So the 2021 guidelines came out in March from the USPSTF. And these are the people that tell us what to do. There's a group of physicians and a board, and they look at all the data, and they look at the studies, and they came up with this. And you drop it to 50 to 80 and 20 pack years, and this is what you do. The problem is it took a year for the Medicare to catch up. It takes a long time for the payers to catch up, because they have to write their book, I don't know, write it till next year. So we waited, and then a year goes by, and finally Medicare's paying for this. And this is something that can get reimbursed, can get paid, it is covered. Now it's covered by pretty much all insurance companies, but there's some caveats. And what I mean by caveats is you have to jump through a few hoops, and Lisa can address that. You just can't get a CT paid for just without going through the right checking boxes, and there's lots of checking boxes to get there. But if you know what you're doing, it's easy, it can be done. You talk to your physician, you talk to your provider, and providers have to know this information. But it is a counseling visit, a documentation of what I love in medicine called shared decision making. Very well with 20-minute talks, and I really don't do very well with 20-minute office visits because there's a lot to say. I have these slides in here, not because I'm going to read them to you, but I want you to know this is what I put together, the next 4 slides, to teach doctors how to get this paid for. And the initial screening services involve shared decision making, and there's guidelines about how to do that. There is counseling you have to do, and it is important counseling. The counseling your provider has to do, or you have to do as a provider, includes not only counseling about the risks and benefits of screening and what screening entails,
you have to counsel them on smoking cessation, smoking. And if they quit smoking, you congratulate them and you do everything you can to make sure they don't start smoking again, okay? So that's important, and that needs to be documented. So these are rules, because if we want to look for lung cancer, we also want to prevent lung cancer, which is help people with smoking. The shared decision-making visit has a code, and one of the things to talk about, everybody goes, why can't I be screened, why can't I be screened? There's actually risks to screen. Not all that worried about the radiation risk, but there is radiation exposure. False positives is the thing you gotta know. If you're going to get a CT, you're gonna find some nodules on people that don't have cancer, okay? So when you go to get the CT, you gotta be prepared, and in this world, your report's gonna show up on your end the same time it shows up on my end. You know, my patients find out they have a brain tumor the same time I find out. I mean, it's kind of scary. It's transparency, but you have to know, I'm prepared for what this shows. My doctor will talk to me, but I may find out before they do, okay? But just knowing you could have false positives, you could have false negatives, that's pretty rare. And also, if you go for one, you're not one and done. These programs went for years. You go for your CT in 2023, and then in 2024, and then in 2020, you don't drop out, and that's what Lisa's job is, to make sure you don't drop out of the program. So Lisa Franks runs our lung cancer screening program at Wake Med. And the benefits, though, are if you find this early, it's curative. Early treatment, less morbidity. People go, I don't want to know if I have cancer, doc. I'm like, yes, you do! Because we're going to take it out, and you're going to go on in life, and you're going to have wonderful retreats with your family. You want to know if you have cancer, because we're going to treat it. I actually have a woman that was very close to me and my family. I've known most of my life, and hers was stage 4 at diagnosis. And she went through treatment, and she's still alive and well 7 years later. Amazing. So these are all, I see it goes on and on. You could go on and on about what you have to do to get this paid for. These are the codes. These are the resources that are available. But my final slide is the assessment tools. It's really easy. The Lung Cancer Initiative, you can have these in your office. They're on the table. Take it with you. Share it with friends and family. You check where you fall, and it tells you whether you're at risk and need a CT. And then on the right, that's my number that I call 919-350-LUNG, and it puts you over at Lisa Franks, and they know all the hoops to jump through to make sure this is done, and they'll keep up with your patient, and they'll keep up with you, and they'll make sure you come back. So I just have to acknowledge Jenny, Dr. Maida, Kathy Hogan, Sarah